I see the crystal raindrops fall, and the beauty of it all is when the sun comes shining through to make those rainbows in my mind. When I think of you sometime, and I want to spend some time with you, just the two of us. We can make it if we try, just the two of us.
Just the two of us.
Just the two of us, building castles in the sky. Just the two of us, you and I. We look for love, no time for tears. Wasted water's all that is, and it don't make no flowers grow. Good things might come to those who wait, but not for those who wait too late. We gotta go for all we know. Just the two of us. We can make it if we try. Just the two of us.
Just the two of us.
Just the two of us. Building them castles in the sky. Just the two of us. You and I.
Hello there, John Aaron here again, and we're going to do the second of the video lectures on advanced hemodynamic echocardiography for the intensive care patient, today focusing on the right ventricle and the pericardium, and this forms part of the GETIT course at St George's Hospital. I am planning to run through some of the basic VICE views with a focus on the assessment of the right ventricle, demonstrate to you what normal looks like and contrast it with abnormal. And then we're going to look at the pericardium as well, and same again. Now, the RV is actually quite a challenging structure. It wraps around the left ventricle and is triangular shaped. So it's actually very difficult to easily depict with 2D echocardiography. As such, you've got to be aware that unless you get the images spot on, you can underestimate or even overestimate the size, shape and function of the right ventricle. So caution is needed when interpreting 2D images. Now, just a quick recap, you'll remember that the right ventricle can be seen in these views: the parasternal long axis, the short axis, the apical forechamber, and the subcostal forechamber. And it's important that we also assess its filling status, in inverted commas, by looking at its IVC. Now, this is a parasternal long axis. You can see, in particular, the right ventricle is seen here. And in this case, it's normal because it forms 1/3 of the whole width of the heart. If you want a more objective measurement, then it really shouldn't be greater than 2 centimeters from its free wall to the septum. And the important thing is also to keep an eye on the intraventricular septum and its relation and how it moves during the cardiac cycle. More on that later. Moving on to the parasternal short axis view, you can see that the right ventricle wraps around the left ventricle, but you often don't see this free wall. So it's very, very difficult to make judgments on its size or even the function of the free wall. What is important, however, is the interventricular septum. Now, it should function as part of the left ventricle throughout systole and diastole. And when you get disease states of the right ventricle, such as volume overload or pressure overload, it starts to flatten, either during diastole or during systole. More on that later. And the apical forechamber view is arguably the most useful for assessing the right ventricle, as long as you get a good apical forechamber view. And to do that, you need to be able to see both the tricuspid valve and the mitral valve at the same time. And you can be relatively confident that you've got a good apical forechamber view to be able to assess the right ventricle. Now here it's not so good, you can't see this free wall, so apologies for that. But overall, if you could, you're looking to compare the size, which should be smaller than the left ventricle, the shape, which should be triangular, and the function, which you can assess in two fashions. The first way is looking at this, which is the tricuspid valve annular plane, and you can see that during systole it moves towards the right ventricular apex. Now we'll talk about how to objectively measure this, but here you'd eyeball it and say its longitudinal function is fine. If you could see the free wall of the right ventricle, you'd also be able to make an assessment about how this comes in towards the septum during systole. Looking at the right atrium size, in this case obviously it's normal, gives you some idea of the filling state of the right ventricle, and also casting an eye on the intraatrial septum and how it moves throughout the cardiac cycle is also helpful. It should swing between moving into the left atrium and moving to the right atrium. If it's fixed and deviated, then it implies that one chamber's pressures are higher than the other, and that is an abnormal situation. To objectively measure, which I'll show you later, you have to freeze the heart just before contraction, at the end of filling, at the end of diastole, and measure the base of the heart. Now, I'm not sure I can pause it for you. So that's not bad. So here you can see the cardiac cycle is stopped just at the QRS complex, and you measure, those lines aren't quite right, where the valve, the tips of the valve leaflets at the base of the heart, so that distance and that distance. And overall, generally, this should be 1/3 and this should be 2/3 of the whole cardiac width. And that's a normal situation. If it approaches 1:1, that's moderately dilated. If it's greater than 1:1, which is RV to LV, then that's severely dilated. Okay? So that's when discussing the shape. Now, I mentioned to you earlier about an objective way of measuring contractility, and we talked about how you can eyeball how the tricuspid valve annular plane moves towards the apex during systole. Well, using M mode, you can actually objectively measure this. So this trace here is time on the x-axis versus distance or incursion on the y-axis. And you can see that by plotting this line here, you have a lovely pattern of how the tricuspid valve moves throughout the cardiac cycle. This being when the right ventricle is filling, and this being when the right ventricle is emptying. And this distance is called the TAPSE. Okay, the apical four chamber is useful, although you can really underestimate the size of the right ventricle. But if you don't get good views anywhere else, you can get an idea of what's going on here. What's this most useful for is looking at the right ventricular free wall. So the right ventricular free wall, this should be less than 6 millimeters thick. If it is thicker than that, there is right ventricular hypertrophy, which implies that there is a chronic afterload problem that the right ventricle is trying to overcome by becoming hypertrophied and therefore producing more pressure to overcome this. So there is a chronic pulmonary hypertension problem, for example, and more on that later. This also happens to be the best view in which to look at any pericardial fluid. Because the liver is a great acoustic window, as is the myocardium. So any fluid would accumulate very nicely here. And you can make a measurement and assess its significance in this view. And then looking at the IVC, which we'll talk about in detail in a minute, you can get a good idea of how the filling of the patient. Now, when we talk about filling, most people talk about the filling of the heart. So in the way that the CVP measures overall global filling, potentially, or at least the trend in change in CVP can infer it. Now, you could start to think about the heart as two separate hearts, one right heart, one left heart. And in that case, you separate out the filling of both these structures. So the IVC really represents right ventricular filling and infers a degree of how it's coping with the volume that it's being delivered to. More on this later, but you can see that over the cardiac cycle, and actually this is over the respiratory cycle, there is this is the IVC, and it varies ever so slightly. So you measure it here and here, and the more it changes during respiration, the more likely it is that the patient will respond to fluid. Now I'll talk more about that in detail. Okay, so let's talk about things a little bit more in a bit more detail at the moment. So when looking at the right heart, it's important to go through the same motions as before: size, shape, function. Okay, and when we talk about the size, we're talking about the cavity and the wall size. The shape should be triangular and not make up the apex of the heart, and its function can be divided into longitudinal, radial, and overall. Now again, we'll talk a little bit more detail about its filling and also its afterload. And these should be concepts that you're familiar with when maybe considering the heart as a whole or considering the left ventricle, but now we're going to talk about them in the context of the right ventricle. So, the size and shape. Overall, if the RV wall is over 5 millimeters thick, then there is a chronic problem. So the right ventricle has been exposed to a high afterload situation and has hypertrophied as a result. And the most common cause is lung disease causing pulmonary hypertension. If you see a thickened RV wall, it implies that whatever is going on with your patient, there is a chronic disease state. Now, we've talked about how to measure the size of the right ventricular cavity. Two ways: subjective and objective. So remember, overall, it should be 1/3 to 2/3 the size compared to the left ventricle. And if it's moderately dilated, it goes to the same size as the left ventricle, and severely dilated, it's bigger than the left ventricle. And that's pretty good. But actually, there are some objective measurements, and overall, anything greater than 48 millimeters at its base is enlarged. At the midpoint, 35 millimeters, and the whole length of the RV should be less than 86 millimeters. Now, you can remember these things, or you can refer to them when you need them. Importantly, the RV should not form part of the apex. Okay, how to measure systolic function. And now there's a number of different measures, going from some familiar, going to progressing to unfamiliar ones. So let's talk about longitudinal systolic function, which is TAPSE, and S prime is a measure. Radial function, which is a bit subjective. Fractional area change, which measures both these components, and global longitudinal strain, which is a measure of how the free wall can produce force. So let's talk about each one in detail. Now, TAPSE should be the most familiar one. We've already talked about it, how using M mode, you can trace how the tricuspid valve annular plane moves towards the apex during the cardiac cycle. You produce a trace like this, and you measure this distance. And basically, anything over 16 millimeters is considered normal, depending on which text you look at. And this is a measure of longitudinal function, which of course is the most prominent way the right ventricle ejects. So most of its ejection comes from its longitudinal shortening. Okay, now radial function. This is a little bit harder to measure objectively. If you see this is the free wall here of the RV. The tricuspid valve seems to be going up and down, but actually this free wall doesn't seem to be moving at all, or very, very minimally, okay? And that's not a normal state. So normally this RV should be coming in towards the interventricular septum more profoundly. Now, again, there's very little objective ways to measure this, so it's an eyeballing thing, and you would comment that there is a lack of free wall movement. If longitudinal function is normal, but free wall movement isn't, you may say that overall the systolic function of the right ventricle is moderately reduced. Now, to try and combine both these aspects, you can do a measurement called fractional area change, which is very similar to doing fractional area change of the left ventricle in its parasternal short axis. You measure the area of the right ventricle at its fullest, at the end of diastole, and at the end of systole, and the difference over the original gives you an ejection fraction. And anything over 1/3 or 35% is normal, and anything less than that is abnormal. The difficulty is, in this situation, is that you can see that the right ventricle is quite trabeculated. So actually knowing where to draw the line accurately can sometimes be challenging. But this is meant to be the gold standard. Now, you can train your eye to look at how this cavity changes during the cardiac cycle. And this is an example of one patient. So this is a single patient who, with volume offloading and inotropy, you can see with your eye in a subjective way the right ventricle has reduced in size, and also the tricuspid valve annular plane is moving more, as is the free wall. And actually, if you look at the fractional area change, look at how much the cavity is changing throughout the cardiac cycle, you can see with your eye that there has been an improvement in right ventricular size and function. Now, tissue Doppler measures the velocity of tissue, which isn't the same as M-mode, which measures the amount that the tissue moves over time. So this is measuring the velocity. I beg your pardon, the dogs saw a cat. So, placing your pulse wave Doppler window at the tricuspid annular plane, you get a trace like this, which represents the velocity of that tissue rather than the distance. Now, the important thing to look at is this value, S prime. Now, this represents the velocity of tissue moving towards the apex during systole. So, the velocity of tissue as it's moving that way. Overall, it should be more than 10 millimeters per second. Anything less than that implies a reduced systolic function. And the last measurement is what's called global longitudinal strain. And this is similar to left ventricular measurements using the same marker. Now, using speckles that appear in the myocardium, the computer software is able to track how much these speckles move in together in relation to each other during the cardiac cycle. And this is a kind of more objective way of shortening, which is therefore a more objective way of measuring force generation. So the computer will track it and then plot the way the myocardium shortens during the cardiac cycle. Produces a graph like this, or it can be represented in a colour form like this as well. Now, overall, when you average out the different segments of the right ventricle, of which they are 3, you should get a global longitudinal strain of over 21%. And in this case, obviously, that is the case. Anything more than that would imply a lack of force generation by that free wall. Okay, so that's talking about systolic function. But now, as we know from our studies of the heart as a whole, cardiac output is heart rate times stroke volume, but stroke volume depends on preload and afterload. So let's talk about RV preload. And the ways we can measure that are using the IVC diameter and how it varies with respiration, looking at the right atrium and intraatrial septum, and looking at the intraventricular septum as well. Okay, so let's talk about each one of those. So first of all, right atrial pressure, which is obviously CVP if you have an indwelling catheter. Now, the absolute value of the CVP is known not to correlate with a volume responsive state or not. It is the change with therapy that is important rather than the absolute value. Now, saying that, we can estimate the right atrial pressure and therefore serially estimate the right atrial pressure to see whether our therapy is useful or not. And this is the way overall how to do it. Now, bearing in mind this is from a long time ago in echo labs, and therefore you could worry about its applicability to ITU. But overall, the IVC, if it's less than 2 centimeters with 50% collapsibility, your CVP is normal. And if it's more than 2 centimeters with less than 50% collapsibility, your CVP is somewhere between 10 and 20. Now, the question about fluid responsiveness is an intensive care question and therefore has been studied in a separate setting compared to the previous study. And overall, again, a very small IVC would imply with a high level of probability that the patient is fluid responsive, and a large IVC would imply the patient is non-fluid responsive. If you then look over the respiratory cycle, if the patient is mechanically ventilated, then the degree of how it changes over the respiratory cycle is also helpful. The distensibility index is something that we use when the patient is mechanically ventilated. Anything over an 18% change represents fluid responsiveness. Now, this patient, apologies, it's not a good example because there's only one cardiac cycle and we haven't actually measured the patient's respiratory cycle. So to not do it properly, you've got to measure several cardiac cycles to get 1 or 2 respiratory cycles. But take it from me, this IVC didn't change. This is fixed and is greater than 2 centimeters. So the patient is unlikely to respond to fluid. And if you plug it all in together, less than 1 centimeter, you're pretty convinced they're fluid responsive. More than 2 centimeters, you're pretty convinced they're fluid not responsive. Now, if it's between those two, then you're in the grey zone, and the more it collapses, the more you can be convinced that they're going to be fluid responsive. 50% collapse with spontaneous breathing and 18% distensibility with mechanical breathing would imply, cautiously, a fluid responsive state. Now, looking at the right atrium, which obviously is upstream from the IVC. This patient has obviously got a ginormous right atrium. Yeah. So the intraatrial septum is very clearly bowed and fixed and actually squishing the left atrium. So this is someone with very, very high right atrial pressures and CVP, which implies that there's something seriously wrong with the right ventricle. And in fact, you can see that this isn't moving, this isn't moving. The apex of the heart is made up by the right ventricle, and you could say the right ventricle looks quite hypertrophied. So there's clearly a big problem. Okay, then downstream from the upstream from the right atrium is the right ventricle. And here again, you'd say there's a big problem. This right ventricle is huge. But in particular, look at the intraventricular septum. So it is flattened. These angles would imply that there is a volume overload or pressure overloaded problem within the right ventricle. So let's talk about RV overload. A volume overloaded system affects the heart during diastole because volume results in filling, which is a diastolic problem. So the main problem with a volume overloaded patients appears during diastole, during the filling phase. And therefore, you're going to get free wall paralysis and you're going to get a D-shaped septum, but predominantly it's going to be diastole during filling. when the ventricle ejects, as long as the disease is not overwhelming, you should get a preserved septal shape during systole. I'll talk about this situation in a moment because I want to focus on preload. So going on to afterload. Now, there's many reasons why you may have an afterload problem, and there are chronic and acute. In this case, obviously, there's an acute problem. This is a large saddle embolus in a patient with COVID-19, resulting in an acute change in pulmonary in RV afterload. And the most robust way of measuring with echocardiography pulmonary pressures is to look at the pulmonary systolic artery pressure. Okay. Now, how to do that? You need TR. Now, during TR, tricuspid regurgitation, by definition, occurs during systole. At that point, the pulmonary valve is also open because it's systole and there's ejecting. Therefore, there is a continuum between the pulmonary artery and the right atrium because the pulmonary valve is open and the tricuspid valve is partially open because there is regurgitation. Therefore, the jet in the right atrium is driven by the pressure gradient between these two. So, using the modified Bernoulli equation, which is 4v squared, once you take into account certain ideals, you can easily, using Doppler, measure TRV max. And to do that, you have to use continuous wave Doppler because this Vmax is going to be fast. And using this velocity and plugging it into the Bernoulli equation, you get a pressure gradient. Now, remember that this pressure gradient is the delta P between the pulmonary artery and the right atrium. To get an absolute pressure, you've got to plus the CVP to it. Okay? And then that gives you your absolute peak systolic artery pressure. So, for instance, in this patient, you measure the TRV max at 4.3 meters per second. Okay? So 4.3 meters per second times 4 gives you 75 millimeters of mercury. And if the CVP is 17, in this case, your pulmonary systolic artery pressure is 92 millimeters per mercury. That's huge. The patient is not long for this world. You can also look at the flow through the pulmonary valve. This is using pulse wave Doppler because on the whole, there should be physiological flow. Now, you can see here the normal waveform and how it progresses as pulmonary pressures increase. Okay, so this is the normal waveform, nice and a single waveform, a nice relaxed curve with no flow reversal. And you can see as the afterload increases, you're getting flow reversal, and more flow reversal. Okay, so you also get this double peak system because you get fluttering of the pulmonary valve as the pulmonary pressures overcome the right ventricular pressures during systole. Now you can measure the acceleration time of this waveform, which is called the RVOT acceleration time, and that gives you an idea if there is pulmonary hypertension or not in that kind of cutoff. 110 milliseconds is normal, so quite long because it's very relaxed, there's no issues, there's no working hard, you're not trying to rush to eject blood before the pulmonary artery pressures close the pulmonary valve prematurely during systole. Shorter than 105 milliseconds implies there is pulmonary hypertension. Now, if pulmonary systolic artery pressure is not enough for you, you can also measure mean pulmonary artery pressure and diastolic pulmonary artery pressure using pulmonary regurg. Okay, so if there's any pulmonary regurg, you see a waveform like this. I'm sorry, these arrows haven't ended up in the right place. But this value here corresponds to mean pulmonary artery pressure, and this value here corresponds to diastolic right artery pressure. Again, using Bernoulli equation of 4v squared. So you plug this velocity in and this velocity in, and you get the different pressures. Now, I wanted to talk about this. I wanted to revisit this slide because RV overload could be volume, which we discussed before, but I want to talk about pressure. So high RV afterload implies, again, the RV dilates, the free wall's paralysed, and there is D-shaped septum. But this time, the problem is a pressure problem. So the RV is unable to overcome an afterload, which it tries to do during systole, not during diastole. So first of all, flattening occurs during systole, and then progresses to the whole cardiac cycle. And if there's a chronic problem, you're going to see some hypertrophy, if the problem's been there for weeks to months. So let's look at some examples. Here you have a parasternal long axis, and straight away the RV takes up a large space of this view. These two look smaller in comparison, and importantly, you have to be aware that this RV is pushing the septum, which is then going into the left ventricular cavity, and actually it seems to be impeding flow out of the left ventricular outflow tract, and that's what causes sudden cardiac death in patients like this. And again, same problem, the RV is clearly very large, and there is septal flattening. It looks like, to me, like there's a problem throughout the cardiac cycle in this situation, which would probably suggest there is an acute pressure overloaded problem, which is so profound that it is causing cardiac septal flattening throughout the cardiac cycle. And here in the apical forechamber, it starts to take shape. The RV is at least as big as the LV. The tricuspid valve is moving, but this free wall isn't. And if you then focus in on the ejection fraction of the right ventricle, it's actually not changing very much. The right atrium also looks big, but I just want to show you why the tricuspid valve is sometimes misleading. So the tricuspid valve here seems to be moving up and down, but actually what's happening, if you look at this septum, the left ventricle is pulling it this way. So the tricuspid valve isn't really a good measure in this situation of overall right ventricular fractional area change. It's really what's happening is the left ventricle's pulling the right ventricle across, resulting in this kind of movement of the tricuspid valve. And here you can see preserved RV apical contraction, which is called McConnell's sign. And it's meant to be pathognomonic of a PE, but anyone knows who looks at echo during a recruitment maneuver is that you can cause it yourself if you try hard enough. IVC here over the respiratory cycle this time, a much better image, and you can see it's not really changing despite ventilation, and it's more than 2 centimeters, so unlikely to be fluid responsive. And of course this represents a PE. It's a dilated and impaired right ventricle, flattening of the septum, and you may be able to see a clot in the pulmonary artery or right ventricle, such as this. I'll talk quickly about pericardial effusions. It's something that we teach to look at FICE. It can make a massive difference to whether someone survives or not, depending on whether you identify it and whether you intervene rapidly. And you report it as either no effusion or trivial, small, and anything greater than small should trigger a cardiology assessment. And these are the objective measurements, and these are the biggest you can make it. So none or trivial, 0.5 centimeter, small, up to 1 centimeter, moderate, up to 2 centimeters, and large, greater than 2 centimeters. And here you can see a pericardial effusion quite clearly. It seems to be circumferential, and the heart it doesn't look tachycardic, doesn't look like it's under a great deal of duress, but this right ventricular free wall, which you see very nicely here, looks a bit wiggly woggly, which implies there might be a little bit of external compromise there. Here again, pericardial effusion seen quite nicely. Now, obviously a very significant pericardial effusion in this case. And the question is, does this need intervention? Now, that's a very good question. Overall, my take-home message is your echo shouldn't be the thing that determines that. If your patient is shocked or unwell and you see this image, the answer is clear that pericardial effusion needs draining. Okay. If you're a purist and decide you want to make further assessments with echo, you look at the RA free wall and the RV free wall. Okay, so what are you looking at? Now, remember your physiology. The right atrium, the pressure should be highest during systole because that is when the RA fills. During diastole, the RA is emptying into the right ventricle, and that's when the pressure is lowest. So the RA is filling during systole, which means that if there is collapse during systole, you're impeding the filling, and that is a problem. Now, similarly, if the RV fills during diastole, okay, during systole, the RV is ejecting, the pressure is low, but the RV should be filling during diastole, and therefore, if there is RV collapsed during diastole, that's a problem. You're preventing filling of that chamber, and therefore your cardiac output is going to be reduced. And the way to do that is to take your image, pause it, and run through it slowly, backward and forward, to try and figure out at what point in the cardiac cycle the collapse is occurring. Now, bearing in mind, there may be pericardial effusions and pleural effusions, and both, and you've got to be able to differentiate between a pericardial effusion and a pleural effusion. So just remember that tamponade is a clinical diagnosis. Hemodynamic compromise, if it exists clinically and there is an effusion, it is that effusion until proven otherwise. And the only way you can prove it is to drain it. Now, if you really want to go to town on your echo, if there is RA collapse during systole, RV collapse during diastole, and a massively dilated IVC with reduced respiratory variation, that would add weight. If these things are not present, it does not rule out tamponade. Now, the swinging heart is a sign that there's a large pericardial effusion. It doesn't necessarily mean there's tamponade. And actually, this is the phenomenon that causes electrical alternans in your ECG. The heart swings and therefore changes the axis of your QRS complex. So, you'd be very concerned about this patient. There's clearly some exaggerated RV free wall movement there. I'm not even sure I can see the right atrium there. So, very concerning. And here, look how the heart is swinging left and right, and look at this free wall, how it's moving. Same again, very concerning. And the IVC, in this case, is fixed, dilated, 3 centimeters, not moving. And it's another example. So, with that, I will draw this talk to a close. What we've talked about is some of the more advanced ways you can assess the right ventricle and the pericardium. The right ventricle is a tricky structure to image and assess because it wraps around the left ventricle and is triangular, and therefore you can really get it wrong. Being meticulous with the way you capture images and only interpreting good images is a way to succeed. Think about the size of both the RV free wall and also the chamber. Think about the shape, it being triangular and not taking up the apex of the heart. And to think about its function. And TAPSE is only one aspect of its function. Think about how the free wall is moving, think about how the whole thing ejects, fractional area change, and also think about using techniques such as S prime and global longitudinal strain. Now, the right ventricle in itself is its own structure and therefore has its own relationship with preloads and afterloads. And you can infer some of these things by knowing your physiology and applying it while doing your echocardiography. I hope this has been useful. You know where I am if you have any questions. See you out there.